Hello, everyone, and welcome back on the Akar and Koka Report. Our guests today are Drs. Rebekah Bernard, a family physician from Fort Myers, Florida, and Dr. Niran Al-Agba, a pediatrician from Washington State. Both are returning to the show, and we're delighted to have you. And both are authors of a soon-to-be-released book entitled Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. Rebekah and Niran, welcome to the show.
Thank you for having us.
We're delighted to have you back. So your book, the title is self-explanatory. The Patients at Risk, self-explanatory, maybe some will need explanation, but you dedicate the book to a woman named Alexa Ochoa-Dawkins. And I'm wondering if you can tell us the story here, and that will set the stage for the rest of the conversation.
Sure. First of all, thank you for having me back on the show, having both of us together to talk about this. And Alexis was a 19-year-old girl who was a bit of a passion project, I think, for us both, meaning that we read about her malpractice, the settlement, which was for wrongful death, against Mercy, Oklahoma hospital conglomerate, and then the physicians and the nurse practitioner involved. And once we delved into the story, it sort of had every element of what's wrong in healthcare today across the country. So she was a healthy 19-year-old girl. She was an honor student. She was an athlete and really in the prime of her life. And she began having chest pain and passed out when she returned to her dorm with her boyfriend. And actually, what you should know about her boyfriend, which we don't necessarily tell you in the book, is that he was her childhood sweetheart. Their families had grown up together. They were very close. And so someone who really cared about her and was like kind of a life partner was with her when that happened. So they called an ambulance and the paramedics came to the dorm room, picked her up, took her to the hospital. And in Oklahoma, despite it being a supervisory state, there was a nurse practitioner working alone in the ER that evening. And over the course of the next roughly 11 to 12 hours, Alexis deteriorated, never really having the correct diagnosis. And she came in, like we said, with chest pain and passed out really early in the course of her hospital care. And that boyfriend who was with her kind of could recount everything that had happened. And the nurse practitioner who took care of her had canceled a chest CT early on, ordered a head CT, thinking something was wrong with her brain, and a drug screen, which she thought was very important, and ended up really getting tunnel vision about a diagnosis of methamphetamine toxicity. And because there was this odd presumptive positive for methamphetamine, but negative for amphetamine. Mm-hmm. And not having the scope of knowledge, she really stuck with that instead of looking at the fact that she was short of breath, had low oxygen levels. Through the course of the evening, she was mismanaged in so many ways. That's part of our book. And ultimately, after calling for help, the nurse practitioner, Antoinette Thompson, the physician who she contacted, who was not her supervising physician, recommended a CT scan. She ordered that CT scan, still diagnosed her incorrectly, transferred her to a different hospital. And while she was being transferred, she was diagnosed correctly with a pulmonary embolus. At the new hospital, when she arrived, they did everything they could and she died.
Okay, well, that's really a tragic story.
It is.
But so I'm sure, many people are not aware that if they go to the emergency room, they might be seen by a nurse practitioner and with various degrees of supervision. What's the background? How did that come about, and what's the scope of it? So, can you maybe walk us through the history of it, of the emergence of the nurse practitioner movement?
Well, I'd like Rebekah to take that because she's.
Yeah. Well, Michelle, first I wanted to point out that, yes, you may walk into an emergency room and be treated by a nurse practitioner, but in this case, in Mercy, El Reno, Oklahoma, the website of the hospital very clearly stated, in fact, they advertised, we have emergency physicians on staff 24/7. You will be seen by a physician. It was everywhere. The patient, Alexis, her family, they were under the assumption that they were being treated by a physician. In fact, Alexis's boyfriend, when he learned that they were actually treated by a nurse practitioner during a deposition, he broke down in tears and sobbed because he had no idea. And everyone was under the impression that this was a physician. So one of the biggest challenges that we see in healthcare, and one of the reasons that we've written this book, is because we want patients to realize that they need to start asking these questions. And in this case, after you look at the deposition testimony, you can see that this hospital deliberately went through significant effort to employ nurse practitioners. They actually went around, they talk in emails about working around state law, working around hospital staff bylaws, and doing everything that they could to replace physicians. And that's what's happening in corporations across the country. This is a multi-billion-dollar corporation that had layers of corporate protection set up to protect themselves in the event of a suit, as happened in this case. And none of the corporate leaders faced any repercussions or took any responsibility for their role in basically the death of this patient.
But tell us, those are very good points, but tell us a little bit, give us a background about what is a nurse practitioner and when did that title even come about? I mean, it's not super recent.
The first nurse practitioner training program occurred in 1965, and it was created by a physician, Dr. Silver, out in Colorado. And he had this idea that you could train nurses to become what he called them child care associates. And this would be for nurses to have advanced training so that they could perform well child care, perform immunizations, and provide education and work side by side with physicians. That was in 1965. Within just a few years, the number of nurse practitioner programs began to grow. And now there are over 400 nurse practitioner training programs. There are over 290,000 nurse practitioners practicing in the United States. So in a relatively brief period of time, a rapid explosion of the profession.
Mm-hmm. And so essentially what you describe is kind of a physician. I mean, there's another term. You want to clarify what the distinction between what a nurse practitioner is and a physician assistant?
We call them both non-physician practitioners. I think they go, obviously people refer to them by a number of different names, but I think mid-level providers or physician extenders, and they really don't like that term, and I don't see any reason we need to refer to them in that way. I think just saying a non-physician professional or a non-physician practitioner is kind of wrapping it all together. And it's
but the idea from, I mean, initially, at least in the 1960s and 70s, was to train people with certain specific skill sets, not just general nursing, but something more specific, to work alongside doctors to perform certain tasks.
Right.
Perhaps perform those tasks independently, but perform them under the supervision of a physician.
Right. And what's interesting is that the first physician assistant program, which was also created by a physician in the 1960s as well, the first one was at Duke University. The idea was that there were these military corpsmen that were returning from the Vietnam War, and they had significant training as medics. So the idea was to take these sort of trained medical personnel and give them additional training so that they could provide primary care. And what's really interesting when you look at the origin of these professions is that the idea was always to increase access to patient care in underserved areas. And that's been a big aspect of the non-professional practitioner growth, is this idea that they're going to provide additional access to underserved areas. And which is well-intentioned, but unfortunately has not turned out to be the reality, and is certainly not the trend that we're seeing today.
You know, the one thing I would like to comment about that was probably extending or broadening the scope for nursing that worked well was the Burlington randomized trial. And there were two family physicians in Canada who really had full practices and couldn't keep up with the demand. And what's interesting is they had two longtime nurses in their practice, and they had these nurses go to a year of schooling and then come back and see a lot of the chronic conditions, the follow-up, and some of the more straightforward kind of independent care that really I think is appropriate for non-physician practitioners to provide. And what's so cool about that study is they were able to expand their ability to take on new patients actually by 22%. So they were able to serve more patients that way using this model. And I think it's a beautiful model. And I think it's been shown over and over to be very effective and very safe. And what's happened is we have a train that's kind of gone off the rails here in the United States. And that's really more what our book kind of focuses on.
So connect the dots between what was the initial intention and the initial development in the 60s and 70s and 80s to the nurse practitioner that took care of this young woman that you just described. What was her training, and what's different about her situation, her professional conditions compared to what it was 30 years ago, which seemed to make sense?
Well, beginning in probably the late 70s and early 80s, what we saw is nurse practitioners starting to seek more autonomy and wanting to be able to practice independently without physician oversight. And they worked really hard to achieve that goal. And in the 1990s, they actually brought together something like 120 different nursing leaders, and they formed a coalition, which ultimately became a lobbying organization. And they had one goal, which was for nurse practitioners to be recognized as independent, quote, providers and to be reimbursed directly from Medicare. And they were able to be successful in getting that signed into law that they could be independent providers. And then just fast forward over time to this continued effort for independence and autonomy to the point where nearly half of the states in the union are accepting independent nurse practice. And now one state in the union is accepting physician assistant independent practice. And I think there were several laws that were enacted that have encouraged this. The 2010 Affordable Care Act, for example, significantly expanded funding for nurse training programs. And that was one of the reasons why we're seeing this massive increase in what I and many people call diploma mills, which are nurse practitioner programs that have 100% acceptance rates. They actually brag about this. They'll accept anybody that applies. No longer have to even be a nurse to become a nurse practitioner. You can come in with a bachelor's degree in anything, and online courses, and basically really watered down training that is no longer accepting the best and the brightest. And so we're seeing these people graduating like Antoinette Thompson. She attended an online nurse practitioner program. She completed her minimum 500 hours of clinical preceptorship. In her case, she did them working with pregnant, healthy women, providing prenatal care in a county clinic. So in no way was she prepared to work in an acute care setting in an emergency department. And this is the new reality that we're seeing with many of these graduates.
It's really mind-boggling what you describe, that somebody would be put in that situation in an emergency room without direct physician supervision.
And what's amazing, we were able to go back through this case. I mean, it had everything laid out really because it's all public record. And there were emails between administrators saying, we just need a workaround. We just need the doctors to be able to have more than one or two nurse practitioners on their license. So had one of the physicians go before the Oklahoma State Medical Board. He was rejected. But even in court, he said, these mid-levels come and go in my life. These people come and go. I don't know who I was responsible for. And when Antoinette Thompson was asked, who's your supervising physician? On the record, it was Brent Wilson, who's a medical doctor, and she didn't even know.
That's because he was never there. He was on site like 4 hours per month at the most. And 90% of the time at this hospital, the nurse practitioners were working completely by themselves, not only in the emergency room, but actually on the hospital floor as well. Right. And they had pretty much, quote, phased out physicians. Again, a multi-billion-dollar corporation just outside of Oklahoma city limits. They tried to use the excuse that rural hospitals have to do this, but the reality is that this hospital was in no way rural.
So tell us about kind of the big players that are behind this engineering of a situation, if you will. I mean, clearly you can see why corporate hospitals or hospital chains would have an interest in putting on their payroll, cheaper labor, so to speak, to fit. Yeah, go ahead.
Well, the labor's cheaper, which is so interesting. It's actually this whole idea of having non-physicians work in healthcare was bought and paid for and benefits large corporations. So the reason it does is, number one, they're, quote, cheaper labor, like you said. So they don't cost as much in their pay. And then what's amazing is most studies show they order more lab tests. I mean, as much as 400% when we're talking about CTs, X-rays, imaging, they order 400. So those orders for non-physician practitioners have increased by 440% over the last few years, while physicians order 35% fewer imaging studies than we did a few years ago. So what's so interesting is that's how hospitals make their money. The more tests, the more studies, the more referrals to specialists, the more things that you need to, quote, do to patients. Benefit hospitals. And so hospitals looking at the situation, do they want someone who knows what tests to order and knows when they're necessary and, treats patients and then sends them out without $1 million workup? Or do they need someone who they pay less and who makes them more? I mean, it's so easy to follow the dots. And these hospital chains are able to do this. And what they do is they don't have hiring handled by their hospital. So Mercy had multiple different corporations, Mercy Oklahoma, Mercy Communities, Mercy Hiring and Credentialing Service. And each of these organizations are separate entities that bear the liability for a portion. So one is the hiring people, one is credentialing, one is staffing, one is medical staff bylaws. And so each of them, have these layers of coverage. So nobody's really responsible. And even the medical director, Douglas Anker, said, and he's a nurse administrator. And he said, well, I don't know what her training is, because they said, well, she's a family nurse practitioner, not even an acute care nurse practitioner. She shouldn't have been in an ER. And he said, well, gosh, I don't know about all that stuff. That's way outside of my scope. And everybody kind of threw up their hands and said, gosh, I mean, we lost a patient, but, it's too bad. And that's really what the frustrating part is.
Right.
And
but go ahead.
Sorry. What's interesting is that the hospital paid $6 million in a settlement for wrongful death. No one got, as far as we could tell, no one got fired. All of the administrators that were still there, that were there at the time, were still there after the trial. But Antoinette Thompson was let go. And she actually was in the process of being fired when she treated this patient. She had done some other things wrong, and they had terminated her, but they gave her the ability to work out her last shifts. So she was actually already fired when she was involved in this tragic case. But then she just very kind of quietly moved out of state and took up a practice in a state, a few states over. And last time we checked, she was still working in a veterans hospital. We recently found out, just before we were able to put this in the book, because it came out just recently, several years after all of this happened, she was finally sanctioned by the Oklahoma Board of Nursing. She received a $1,000 fine, a 1-year suspension, and some continuing education requirements if she wants to work in Oklahoma. And so these are the repercussions that she faced for her actions. And as far as we can tell, she's providing care to veterans in Iowa, which is an unsupervised state. And
Emergency
the VA
care
is unsupervised.
Right.
And it's emergency care still. So she's still providing emergency room care independently.
But is it the hospitals or hospital corporations themselves that pushed the development of these diploma mills, or are there other players or other professional institutions? You mentioned, I think, some philanthropic organizations that can you speak about these other players that also seem to?
Yeah.
I mean, because there's a confluence of interests.
There's so many interests that are involved, and it's really hard to dissect it apart. I mean, first of all, the federal government is extremely interested in the use of non-physician practitioners. They've invested millions and billions of dollars in them, starting back in the 1960s and 70s. In fact, the Rural Health Act of 1977 mandated that federally qualified rural health clinics that receive federal funding had to staff with at least 50% non-physician practitioners. So they've been very interested in this. Of course, I mentioned the Affordable Care Act, but even the Trump era, there was an executive order asking for pay parity. So for some reason, there's a strong government influence involved in this. And then there's private philanthropy, and you alluded to the Robert Wood Johnson Foundation, which was created by Robert Wood Johnson, the founder of Johnson & Johnson, one of the largest manufacturer of household products and a huge conglomerate. And they also happen to make drugs and medications. For example, Janssen is a subsidiary of Johnson & Johnson, and they are a major manufacturer of opioids. And in fact, they got into some trouble recently because of their efforts towards getting prescribers to write more prescriptions for opiates. Interestingly enough, nurse practitioners and PAs write more opiate prescriptions than physicians, especially in states that have independent practice. So you start to kind of look at all this and you wonder, you see a little bit of connections here and there, but the Robert Wood Johnson Foundation has donated millions and millions of dollars to increase nurse practitioner practice. They also have really close ties with organizations like CVS Caremark, which of course has CVS Minute Clinics, which hire nurse practitioners. Of course, those same nurse practitioners write prescriptions for drugs possibly made by Johnson & Johnson. And then they have a relationship with Aetna and United Healthcare, who are involved in deciding who gets, how we pay for these medications and prescriptions.
This whole thing's about money. I mean, the bottom line, everybody's making money. So patients are losing their lives, and physicians and even the other healthcare workers are really getting squeezed. And everybody, from the education at the diploma mills to the insurance companies, to the hospitals, to the organizations like the venture capitalists that are running different clinics and hospitals, they are all siphoning off money. And the people who are hurting or who are being harmed, and that's the whole reason we wrote this book, are people just like Alexis. And that's really the bad thing, is patients are suffering.
What about the nursing profession? The nurse practitioners are licensed by the nursing boards. Is that correct?
That's correct.
Okay. And do you see within the nursing professions or the schools of the nursing, traditional nursing schools, a push, or how? What's the attitude within the nursing community, if you can actually distinguish?
It depends on who you
nursing?
ask.
Okay.
I mean, I think a lot of the nurses that I would call veteran nurses with experience and the education that they had, getting their bachelor's degree, et cetera, and they really are looking at this saying, gosh, I don't want to have an independent nurse practitioner who came from a diploma mill. And so they seem to be aware of this. And there are nurses who are standing up and fighting, but there's this big push to support your own. And we talk about in the book how during one of the nursing closing kind of discussions, it was the best voice is sometimes silent. Saying, and I'm not saying that, I'm saying the person who was giving the talk said that if you don't think independent nurse practitioner or free practice is what we should be working for, then you need to be quiet. And so there's this push even from inside the profession not to say anything about it. But I mean, I talk to many nurses, especially veteran bedside nurses, who say, I don't understand what's going on. I mean, we have very different professions. We have very different, backgrounds. And what we're seeing is really kind of appalling.
Right.
Sorry, you mentioned boards of nursing, and I think one of your points that I think is very important is that these boards of nursing are really not capable of properly overseeing the sheer volume of different nurses. They're in charge of LPNs, licensed nurses, they're in charge of registered nurses, and they're in charge of nurse practitioners. And often on these nursing boards, they consist of LPNs and RNs, and I don't know how they would be expected to judge whether or not a nurse practitioner is providing appropriate care, because they didn't study that. That's not what they do. And we're seeing problems like in Texas, there was a nurse practitioner who was found responsible for the death of 2 patients in overprescribing testosterone replacement and thyroid hormone. It took the board of nursing over a year to sanction him. And it was only because of the efforts of a physician who actually drove from rural Texas to Austin to continue to basically harass the board of nursing until they finally took action. In California, the board of nursing is in trouble there because auditors found that they failed to act on reports, and there was an implication of a death of a patient that the nursing board, if they had taken action, potentially could have prevented that. So I think the answer is the boards of nursing are not capable of oversight properly right now.
Right. It brings to mind something that I noticed, unrelated to the nurse practitioner question, but the nursing, if you look at, my wife went to nursing school. She has a bachelor's in of nursing. The curriculum, what nurses are taught doesn't make sense to me. And that's generally speaking. They get taught things that, I mean, it's like a watered down medical school. And I had the sense that there's no clear distinction in people's mind, either the leadership of the nursing profession, either the nursing schools or the nursing boards or whatnot, what the essence of a nurse is, how clearly distinct it is from what a doctor does. And so they teach nurses things as if, I don't know, it seems to me a lot of nonsense. And to make them like mini doctors or watered down doctors, and instead, and then they get thrown on, in the hospitals, and the truth of the matter is they become paper pushers, right? They are, all they do is document X and Y and Z, and there's very little attention paid to the true role of the nurse, which is extremely important, but it's been sort of, across the board kind of lost sight of, so to speak.
We love nurses. My
We love
mom
nurses.
and my dad, both my mother and father are registered nurses, and I always say there's nothing like a nurse, really. They're fantastic. And we're not opposed to nurses at all. In fact, one of the things we're worried about with this increase in nurse practitioners is that there is a big shortage of bedside nurses. And they always use the nurse practitioner as a reason, well, there's not enough physicians. But they fail to mention that there's not enough nurses. And by increasing nurse practitioners, they're cutting into the supply of bedside nurses. We need to treat our nurses well and support them. And we need more nurses, just like we need more physicians.
Right. No, absolutely. Absolutely. But treat them the way they should be treated, as nurses, and not as, a sort of,
And traditionally, I feel like, again, having grown up in medicine, I'm still in touch with my dad's first nurse, starting in 1970. And when I talk to her after all these years, she's got such amazing experience, especially in pediatrics. He has this knowledge base that I don't see that the nursing schools necessarily teach today. They really did teach about basic systems, physiology, so that both doctors and nurses could work in a complementary way. A bedside nurse is so critical for patients because they're the eyes and ears of everything we do. And somehow that has been watered down, like you said. And I think it's tragic because, again, there was this real complementary thing. Physicians depend on nurses to help us treat and take care of patients better. And again, without their help in the hospital, we're going to struggle. And like you said, now there's this blurred line of things. Well, what is that? Is that a nurse's job? Is that the mini doctor? Is that the doctor? It's a shame because really, I think the system where nurses knew everything about their patient at the bedside is so extremely valuable.
Correct. And the nurse as patient advocates, traditionally, hospitals were nursing places. They were not, and the doctors, if you go back to 100, 300 years ago, hospitals were nursing institutions. And the doctors sort of inserted themselves into that because it was an efficient place, convenient place to see a lot of doctors. And then they pushed away. So the leadership of hospitals was taken over by doctors. Again, I'm not saying that it's right or wrong. It is what it is. But there certainly is a special role for the nurse.
Absolutely.
As a patient advocate, that has been lost and continues to be lost in many various ways, including this push to get them to become nurse practitioners and work independently, as opposed to, again, perhaps being a physician assistant. But then I don't see why there should be. You can train a physician assistant separately without that person being a nurse and whatnot. There's a lot of confusion about what the proper roles of everybody is.
I think it really is political too, because if you look at the Future of Nursing report, which was published in 2008, it was published by the Institute of Medicine, they're called, but it was actually an organization that was largely funded by the Robert Wood Johnson Foundation. It was chaired by Donna Shalala, and the committee of 13 only had 3 physicians, and they were all industry people. One was an academician, but the rest were, one was like the head of an insurance company. And so they're the ones that produced this kind of famous report in which they said that we need more bachelor's trained nurses, which many people say was not a great idea because an associate's path is a quicker path and leads to more bedside nurses. But they pushed for a bachelor's degree, and they pushed for a doctorate of nursing was a big deal. And they called for nurses and physicians to be what they called, quote, equal partners in redesigning healthcare. And so this was really, it's so interesting because this report was actually created by a private corporation or industry, and it kind of became the mantra for nursing programs and kind of pushed the political agenda in that direction. Yet the report did nothing, again, to increase the total number of nurses. It just tried to push nurses towards getting more education and encouraging the transition from master's level program. They want more nurse practitioners to have a doctorate degree. And what's so interesting is that studies show that only 15% of these doctorate or doctor nurse degrees, only 15% of them are even clinical. The rest of them are all research oriented, and they really don't add much to the clinical acumen of the practitioners.
Mm-hmm. So the floodgates are open. So, it seems that way. The chance of somebody, who doesn't have an established relationship with a physician, being treated on an emergency basis, either at an urgent care facility or even an ER and whatnot. So the chance of that person being treated by a nurse practitioner is quite high, is going to be higher, even as primary care physicians. I mean, we see physicians being fired, right? Employed physicians being fired in large numbers to be replaced by nurse practitioners. I mean, what can be done about this? Do you have a prescription?
The prescription. Oh, go ahead.
Do you mind? Do you mind if I? Do you mind if I ask a couple questions? Just to get the just to kind of play the devil's advocate and kind of flesh out some of the things that other folks are going to say. So this isn't just like
Sure.
just this one point of view, which obviously me and Michelle are very partial to. The comment that's made, of course, in response to this tragic case of the 19-year-old with all the different missteps is that physicians screw up as well. For every, a nurse practitioner could certainly write many books on physicians, even good physicians that have had good track records. It sounds like this particular nurse practitioner had many problems, and this is in her last 30 days, as you said in your book. And within the last 30 days is when this kind of damage occurred. So what would you say to the fact that, what would you say back to this idea that, look, you're just picking an anecdote of a bad outcome in medicine. Bad outcomes in medicine aren't always preventable. Lots of physicians go down diagnostic, pathways that are errors and anchor to diagnoses that they shouldn't. Why should we care about one anecdote?
So my answer to this would be, and I know I've actually heard you allude to this, I think when you were talking to John Mandrola previously on this topic, and the scope of the mistake gets larger. And I think there's a couple of things we learned going through this book and spending 3 years doing this intensive research. They basically, in their training, as the non-physicians, do not learn to do a differential diagnosis. And there's an entire section of the depositions where she's asked what a differential is, and there's actually a defendant, another nurse practitioner expert, who comes in and she can't do a differential either. So neither of them can do a basic differential diagnosis. And while some people may think a differential is useless or a waste of time, I can tell you most of us in primary care use a differential diagnosis on a daily basis. And so what I would say to your answer, there are, of course, terrible doctors. I don't really think highly of the physicians who were willing to sign off on the nurse practitioner's charts that worked at Mercy. I don't want to lump myself in with those physicians who were willing to leave the care to people who, honestly, in that ER did not seem to know what they were doing. So I would say what I've seen when I look at the mistakes that I see in my hometown practice, they're huge, glaring errors. And I'll give you an example. And this summer I had a kid who stepped on something sharp in a lake. And she went to the ER, and this dirty wound that most of us would know in our sleep not to sew up was not only washed and stitched closed, it was really stitched tightly closed. And when she came into me, I couldn't see the stitches because the skin had been pushed. It was so full of pus. The stitches, I had to essentially cut blind, which I did to open the wound, and pus came, exploding out. And the thing is, I ended up calling it someone I know. In fact, our kids go to school together. And I said, essentially, please, never, never, never sew up a dirty wound when you don't know what caused the wound. Well, I washed it out was the answer that came back to me. And I said, I'm going to say it one more time, please. In pediatric patients, never, never, never sew up a dirty wound. And certainly if you do, antibiotics would be a good idea. And this kiddo ended up hospitalized with antibiotics and obviously grew something out of the culture. I'm trying to sort of maintain some confidentiality, but nevertheless, to me, I've never seen a physician sew up a dirty wound in all the time I've been doing this. And I think one of the physician experts said it best. A person who's on birth control pills with a low oxygen saturation, low blood pressure on top of it, short of breath with chest pain, is and can only be almost a pulmonary embolus. It's as purely obvious as snow, is what I think he said. And while many people may not get that, if you're not an ER physician, maybe you wouldn't get that. But again, this is a glaring error. This is a differential diagnosis error. And to me, we all make mistakes. I've made them. I'm sure Dr. Bernard, both of you, we've all made mistakes. But I don't know if we've completely missed something that in the differential diagnosis should be really in the top.
Yeah, it it's a
The other
challenge.
problem is just that Dunning-Kruger effect. The big problem I see is that when you only have 500 clinical hours, you can't even begin to know what you don't know. And I think that's the difference with physicians. We certainly do make mistakes, but we have enough experience to know when we're out of our depth or when we know that somebody is really sick and we need to get help. And that's where sometimes people with lesser experience fall very short.
It's very hard to empirically prove. I don't know if we really need to empirically prove it, but I think this was mentioned in the conversation with Dr. Mendrola as well, is that we don't spend enough time talking about, or not us, but folks on the other side don't spend enough time focusing on not just the difference in hours, which is obviously incredibly important in terms of that hands-on training that isn't just necessarily following and shadowing a doctor. It's like you're in the hospital, you're seeing folks come in as an intern. Then your second year is looking in on you. Even when you're a second year, you then have an attending. And that's intense, full-time immersive training for physicians that doesn't exist at the moment for nurse practitioners or PAs in this form. But the other aspect of it, which you touch on in your book, is how you select physicians and how you select folks who become nurse practitioners. Somebody mentioned it earlier in terms of the diploma mills that nurse practitioners are, and that anyone can basically go and join. Not anyone, at least until now, not anyone can go to med school. The filtering process is huge. I mean, you start out with the bright people in high school who were like, okay, if you're super bright in high school, we want to do medicine, and you go, how many pre-meds do you start with in that freshman year? I went to Penn State, so there must be 6,000 people in my class. Half of them were like pre-med. And then from there, you don't do well in Chem 1. You have to take organic chemistry. You have to take physics. I mean, these are, reasonably speaking, rigorous, much more rigorous than the average person in many undergrad places do. And by the time you're done, you then have around 48,000, 50,000 folks that are then applying to medical school. And then from there, only a third get accepted into medical school. You can't pay your way. Well, most of us can't pay your way into medical school. So, that selection process plus that immersive clinical training, would seem to imply that the scale of error, the bandwidth in terms of how much error we're going to make, should be much different for the average physician that a patient is coming in to see versus the average nurse practitioner patient coming in to see. Because it very well may be that there's and I know some amazing nurse practitioners that certainly could be physicians, have a breadth of experience, know when, the Dunning-Kruger thing you're describing, it's this understanding when you're in hot water, when to ask for help. But it's a very, very dicey proposition for some administrator in some health system to say, oh, okay, you are certified for NP school. Let's put you alone in an ER where you're seeing a 19-year-old with a heart rate of 140, the low blood pressure and low pulse ox, and expecting that person to quickly diagnose a PE. And then once you diagnose the PE, then you have to God forbid, then what do? You have to make the right calls. It's a very, very tough thing to do. And I really blame the nurse practitioner. I'm sorry I'm talking so much. I really blame the administrators and the leadership of nurse practitioners that are putting their poor folks, in positions like this. It's really
Absolutely.
terrible. I mean, really,
Absolutely.
really terrible.
Yeah, we totally agree. And we actually had a nurse practitioner student who dropped out of nurse practitioner school because she felt that the training she was getting was inadequate. She reported them to the credentialing organization. She reported them to the American Association of Nurse Practitioners, and she just got nowhere. In fact, she's getting a lot of cyber bullying by other NPs for speaking out. But you're 100% right. And especially when they are told specifically that if you hear someone talking badly about full practice authority, the AANP actually has a website reporting link where they encourage anyone, especially nurse practitioners, to rat on each other and report it, so that these people are afraid to even speak out. And I know many nurse practitioners are being put in a bad situation that they're not prepared for. And actually, I feel sorry for them, not as much as I do for the patients, but we actually kind of felt slightly bad for Antoinette Thompson. We
Yeah.
felt like, she wasn't a bad person. She was trying to do the best she could. She just wasn't properly prepared. And yet someone told her that she was, and that would have been the nurse practitioner organizations. And then of course, the corporations who capitalized on it and profited from it.
And I want to talk just a second. You touched on empirical evidence, and what's so interesting about empirical evidence, you can't always get answers to these questions that we have. And what I found fascinating is when we started to delve into the studies, what was so remarkable is actually there are 5 decades of research to show that nurse practitioners and physician assistants can provide safe and effective care when they're supervised by physicians. I mean, it's unarguable. That is such a great, system and plan, and the way it's being done when they're seeing patients that are chronic, that are needing follow-up in rheumatology, even cardiology, all the way across. When they are seeing these chronic, what we would call not undifferentiated patients, they really provide outstanding care and the patient benefits. So my thoughts after Rebekah and I had talked about this, I was like, look, I can't find a study that's in any of the major databases where physicians weren't supervised. And she said, you're kidding. And then when we started going through it, people would say, well, what about this study? And what about that study? And like, nope, none of them, they're zero. They're all supervised. And so how did we go as a nation? Really, if you want to look at hydroxychloroquine, like craziness this year, oh, there's no studies, we can't use it. Fine. If we don't have studies that show something's effective, great, let's really try to have those studies. But here we have studies that show it is wonderful addition to have non-physician practitioners working with physicians, being supervised by physicians, providing care for patients. So how did we get from there, which is really proven well scientifically, to, oh, what the heck, let's just throw everybody out of the airplane and go on your own. I mean, let's just kind of see what happens. How bad can it be? And that has happened.
I think it's very, it's of course, does that mean? It's of course very hard to do these studies.
We've done them. They're amazing. Why don't we just follow what's in the study?
Right. Well, but for instance, the Mundinger study from 2000, right? That was
Let's talk about that.
That was the JAMA study in 2000 that looked at 17 physicians and 7 nurse practitioners. And there were 1,300 patients, predominantly low-income Hispanic women. And, the patients were either assigned to a nurse practitioner run or physician run primary care practice.
Can I tell you? Can I tell you the details about that study?
Yeah.
So, and you're heading to say, like, they had 3 different conditions: hypertension, asthma, diabetes, and they showed no difference. And it's a wonderful study. It's groundbreaking. And Mary Mundinger really had great intentions, and she foresaw this physician shortage and said, hey, we can fill these roles with nurses. So those 7 nurse practitioners all were appointed to the Columbia School of Nursing. They're all assistant professor level. 3 of them had doctorates. So there were 3 pediatric nurse practitioners, 4 family nurse practitioners. They went through a 6-month residency to get extra training in cardiology, radiology, dermatology, and were mentored specifically by the physician supervisor that they chose as their backup. They were mentored specifically by those physicians to learn how to do hospital admissions. Within 24 hours, the hospital protocol, which was published in her book, which of course I've read, showed that a physician had to sign on the hospital admission within 24 hours. Pediatric doctors would not allow the pediatric nurse practitioners to admit independently, so they insisted that they work together. And Mary Mundinger is quoted as basically saying, each nurse practitioner in the study chose her own supervising or collaborating physician, because obviously that was the law at the time. And they agreed to be on call immediately to respond if a nurse practitioner needed help.
Right.
It's a wonderful study. It's well done. Yes, there's some bias and some other issues, but again, they're supervised. They're not independent.
It's not an unsupervised study, even though they love to use this as an example. But when you actually delve into the fine print, physicians were around, physicians were available, and physicians were mentoring these nurse practitioners.
Right. Which is what that's what I was leading up to, is that it's incredibly hard to decide. You'd have to take nurse practitioners, put them on an island, and not allow them to talk to physicians, right? But that's not reality, though, right? Meaning, is it possible to have, based on what we know as reality, to have NP run clinics with a call of, with a quick call available to physicians? I mean, so I mean, is that a workable model?
I think it is. I mean, I think Mary Mundinger proved it is a workable model, but here's what you need. Number one, you need to eliminate the diploma mills. Number two, you need to institute residencies for nurse practitioners. Number three, whoever, these 7 nurse practitioners were very experienced. They were assistant professor levels, and 3 of them had doctorates. So yeah, if you want to set a bar of experience years, application years, going to having clinical hands-on experience number of years, and then completing a residency with a physician, great. That's what that study tells me. Maybe other people are getting something else, but I think, yes, you can spend time training someone who's not a physician to do undifferentiated patients in a primary care clinic. I think Mary Mundinger showed that, and I think that is something that's worthwhile exploring. But that's very different than allowing online schools and hiring people randomly to work alone.
No question. Here's the really hard question. Why is there, do you think there's a real demand for nurse practitioners from the populace, not just healthcare system corporate CEOs? Do you think there's an actual driver for demand in the way that this is a terrible analogy. I don't mean anything bad by it, but this war on drugs has been going on since God knows when, right? But part of the problem with not being ever able to get ahead of the war on drugs is that there's just this burgeoning demand for drugs. I mean, on the streets all the time. I mean, which makes people rich in Colombia and wherever. Is the massive explosion we've seen in nurse practitioners and PAs, is that driven by real demand from the market?
I think that when I look at my community, and I'm a primary care physician, my phone rings off the hook for people looking for a new primary care physician. Now, I do direct primary care now, so most of the time when they hear we don't take any insurance, even though we don't charge very much, they hang up immediately and don't even let us give the spiel. But the answer is there's a huge demand for primary care. So that I would say, yes. There's also a huge demand for, not in the same way as drugs in any way, because the marijuana clinics are also popping up on every corner in my neighborhood, in my medical marijuana state. But there is a demand for immediate answers. I have a runny nose and I want an antibiotic, today. Or, I have a migraine so in other words, we want a quick fix. And of course, that's part of our society. And you can pop into the Minute Clinic or the walk-in care clinic, and you can get your care quickly. Maybe it's not great care and maybe it's not appropriate care, but you can probably get a prescription for something real quick from a nurse practitioner. So I suppose there is a demand in that respect.
I don't think there's a demand. I think there's a demand for care. And I think what's happening is people will say, oh, the nurse practitioner or the PA is available. They're the same as a doctor. And so just to see them, and that's fine, I guess, but it's not specifically for a nurse, for a non-physician.
Well, but I think you're outlining the problem, because I think what I'm seeing in a variety of different places is that we are not, as physicians, we're not able to fill the gap in a variety of different places. So I was just with a very sick patient, terrible case in the ICU the other day. At 6:30 p.m. The patient is incredibly ill, and really terrible things are happening. I'm there. There's another physician. No, actually, I think I was the only physician there, right? No, I was the only physician there. And it was an ICU, and there were 7 nurse practitioners there. And I have to tell you, I mean, it was amazing to me, because my entire training has been with, residents and, fellows in that type of a situation where we're all working on a very sick patient. I'm acutely aware of the fact that the current crop of residents, it may be hospital specific perhaps, but the current crop of residents, certainly in this hospital, have zero interest in being there and dealing with this incredibly sick patient who's going through multiple different bad rhythms, trying to diagnose a pericardial effusion. Is there an aortic root abscess? Does he need a transvenous pacemaker? I mean, an intraosseous line. We can't get a femoral line. Emergent subclavian line. This is. I mean, some pretty high complexity stuff. Balloon pump. Anyway, I can keep going. This is all happening in one patient. but you all of us on this little panel know what an amazing amount of learning there was for any resident or intern at, who was there, watching and seeing the physiology of all this stuff playing out. And guess what? There's not a single resident there now. It's all nurse practitioners. And by the way, they were all very, very, very good. They're all been there for a while. This isn't residents who rotate out every 2 years, or a resident who wants to do ophthalmology who's in the ICU kind of looking with wide eyes. They're like professional ICU NPs, and they're there because there is no resident who necessarily wants to be there doing this type of work. So they're the ones placing the lines and all this stuff. So is it partly driven by us is my question. The fact that we don't want to do this work, and so they're kind of filling up.
I think partially, but we're also hearing from residents all the time that they are losing the opportunity to actually get involved in patient care, that they're shoved out of the way by nurse practitioners, that they are being replaced by them, that they're being taught by nurse practitioners. And what I'm hearing from our colleagues that are in training is that they're actually being pushed out of the way. And many of them want to do this kind of work, but they're losing the opportunity. Look at all the medical schools that are now training NPs and PAs. We're even hearing medical students that are not being able to scrub into surgeries. They're not being able to do procedures because of this.
Do you know why this started, though? I mean, I think that's going to happen. I think residents who are smart, who get it, are going to understand what the heck is going on. It's like, my God, this is training that we should be doing in order to fill these roles. But I'm telling you, this is a product. This is a self-inflicted wound. You introduce an 80-hour work week, and suddenly you have shift work, and suddenly you have a certain number of things that can be covered. But the hospital is huge and has all these needs. Guess what happened? The hospital in the acute care setting was like, well, okay, we're gonna have hospitalists. Okay, fine, you have hospitalists in there for a while. Hospitalists, are at least where I'm in a big city, which is actually more competitive. Salaries are lower, probably around 220, 230K. Nurse practitioners are there now in an ICU setting doing this for 120K. But forget about the primary care, the intensive care setting. In the primary care setting, as you're saying, correct? Do you find that and Niran, this, your wonderful stories about your father. My God, I mean, when he started this practice, right? I'm sure, and I know I'm a solo practice guy, as is Rebekah. All of us are. It's an intense, and that's what we do now. It's intense, right? I mean, you're there, and you have to be there constantly. You're constantly getting calls, the stress of running the practice, business, etc. Do you find that in the primary care setting that for whatever reason, the folks that are coming out, they gravitate to this kind of shift work type of mentality. They don't want to cover all these shifts. And again, who's sitting there waiting to, kind of salivating to kind of have these opportunities to be there, do this stuff? They again are the NPs, and they're willing to do and cover those shifts that primary care folks don't want to cover. There's been a shift also from mostly male, primary care to increasingly women in primary care, correct? And again, that of course, there's so many roles that for a variety of societal reasons women have to fill. And how do you run or are intensely involved in a practice and also have 4 kids and pick them up at school? But it's just it's very hard. Yeah. Is that playing a role also?
Well, sort of. I think what's happening is we don't have as many physicians going out into primary care. We have more people that need care. And, I feel like I've somewhat been able to find a balance with the 4 kids and the working part-time. And I have patients that are I'm on 3rd and 4th generation now patients, right? So my dad took care of their great-grandparents or grandparents and so on. They've been coming to us since 1971.
Yeah.
We're going to celebrate 50 years in January. And so, there are fewer and fewer practices like that. But what's so interesting to me, when you were talking about the ICU, I ran my dad's care. I mean, I still laugh about it because I remember he's on the balloon pump. He needs stents. All 3 arteries are blocked. Wonderful cardiologist was like, I don't know. And I looked at him and I said, dude, if he dies on the table, that's expected. I get it. Nobody's going to sue you. Take him and give it a shot because we are realistic. We know what's happening. And I remember the afternoon I walked in after the stents were successfully placed and he couldn't get off the vent. And I said to the ICU doc, I was like, he needs a trach and, or we need to let him go. And he goes, no. And I said, okay, I'm going to go talk to him about a trach and figure out what he wants to do. And then you can decide whenever you get around to it. And so I did. I went and talked to him. My dad wanted a trach as opposed to letting him die and letting him go. And I was real clear with my dad. And I remember leaving that night and thinking, like, I wonder how long it's going to take the ICU doc to decide he needs a trach. Next morning, he's like, I think he needs a trach. And what's so funny is we got all this training. Why do we spend time in the ICU? I mean, I'm a primary care doc. Why do I do that? So that I can understand what an anterior mediastinal mass is. So I can recognize sepsis. So I can recognize a kid who needs to be admitted to the hospital. And the problem is, I think what's going on is we've made a mistake in education. We've said, this is just a primary care person, right? Whatever it is, PA, nurse practitioner, they're just going to go into primary care. So they just need to see well childs. Like, why would they need to fly in the helicopter? I mean, my best training was as part of Life Flight 1 in Colorado, landing on people's lawns and, adults and, doing cardiac stuff and putting in lines, putting in, needles for pneumothoraces. Like, that is what I needed. I don't do it every day, but when somebody aspirates something, I sure as heck can recognize it and get them the care they need. So again, I think there are some levels of education. And then there's been this idea that primary care is just easy. I remember Mandrola said, I could teach anybody to put in a pacemaker. And what's funny is I thought at the time, like, well, of course, I mean, I guess, but I can't teach anybody to do my job. And I use Krebs cycle. We were laughing about Krebs cycle, right? I used it. I get kids with metabolic disorders. I mean, I still diagnose OTC deficiency in family members that I've seen over multiple generations. I still have to use Krebs cycle. So how do you train someone to do my job? I don't know how you do it. And that's the problem here. But yet there's not enough of me to go around. So then what do you do? And I completely agree. I just think the answer is if you have to add someone, like I have now had to add a nurse practitioner. I don't employ her. She's in her own independent practice, but we collaborate a lot. And the thing is, I think you try to have them manage and follow and learn things along the way and almost apprentice. And I'm investing in this one person. She went to clinical programs. She's got the full training. She didn't do a diploma mill. She's very bright, but even she has been like, oh my gosh, I had no idea.
Right.
And that's what I think we do. Like those physicians in the Burlington trial. I think those kinds of approaches are going to be safer and better in the long run.
Right, but you're facing a similar problem. I mean, in your practice, right? So you're 3 days a week, and in order to provide coverage, 4 days a week. But in order to provide coverage, your other person is a nurse practitioner. You have a nurse practitioner.
Right, sort of, but it's not coverage. I cover all my own patients, and I have a way.
But she has her own patients, and then you collaborate. And then you collaborate in a close manner.
Right, she's building her own practice, and I am working with her, and I think it's going to take a number of years. But I want to invest in this because I no longer have the capacity. I'm like those two family docs in Canada who said, "Can we have some help so I can increase capacity for seeing patients?"
Yeah.
And
it's a demanding. Where are the physicians that want to do what you do, Niran? I think they're not there anymore.
It's really tough. In my practice, it took me several years. I just found a young, just graduated from family medicine residency, and I'm trying to sort of do what Niran's doing with nurse practitioner, but with him. But it's been so hard to find someone. I don't know if he's going to stay. It is really hard to find physicians. And of course, they come out of school with a lot of debt. And so many of them are lured into this idea that they're going to get some kind of nonprofit payback if they work X number of years. I think it's mythical. I haven't met anyone who's actually gotten that money, but it lures them and it keeps them in these large hospital nonprofit systems. And it makes it harder for them to want to take a chance on doing a private practice.
I'm raising children who want to do this. That's my main hope. We've got 2 out of the 4 that want to go into medicine. So hoping we're going to get a 3rd generation to keep the practice going. That's all I've got.
But, the system is so fragmented, and it's such a, it's been the problems are longstanding from many generations. I mean, the way medical education is for physicians, as you described, Anish, has built-in problems that lead to this, and it's not really in our hands as individual physicians. There are, things beyond our control or seemingly beyond our control. I mean, normally, if it was the same, you'd be training your own physician extenders but you'd be responsible for them. So I mean, you'd be accountable. I mean, the job of the doc at the end of the day is to be accountable, but you can't train anybody. They have to be this. So the system, the legislatures, which are ultimately responsible. I mean, we elect them, so so collectively we're responsible. The legislatures are imposing these systems that are extremely costly, that promise everything to everyone, to the point that nobody gets anything, and it's really it's catastrophic. But I'm not very hopeful. What is your aim with the book, Rebekah, to correct this? I mean, what can we even hope to
we
do?
worked with I've been really involved with this organization, Physicians for Patient Protection, and and also with my Florida Medical Association and my medical societies and all different things, to try to work legislatively to get change, to at a minimum get truth and transparency laws so that patients will at least know. And I've kind of hit so many barriers and obstacles with this that part of me, I don't necessarily want to give up, but I realize that this may not be the correct tack. Instead, I think what's important and what we've decided to do with the book is to try to get the message out to patients. I'm a big fan of free market, and I know you are too, but the only way we can have a free market is if patients have the understanding and the knowledge and can be empowered. So the idea with this book was to tell the story, to let patients know that there is a difference, because the propaganda that they're hearing, and they're getting these marketing campaigns that says, oh, don't worry, NPs and PAs are the same as doctors, they do just as good. So we want to just say, well, let us give you a different perspective. Let us help you understand the differences, and let us tell you what you need to know, what you need to ask, so that you can make the best decision for your own healthcare, so that you can ask the right questions and make sure and demand a physician if you need one. Because many times, for example, in Texas, they fired 27 pediatricians, replaced them with nurse practitioners. The only way they can get away with that kind of thing is if patients accept it. So if patients come in and say, where's my doctor? No, I'm not going to see a nurse practitioner. I want a physician. That's really the only way that we're going to see the pendulum shift, by the demand.
And the only thing I would add to Rebekah's statement is, I've given up on politicians. I've given up on the legislatures. I've given up on the insurance companies. I've given up on the hospitals. Like, really kind of been doing this long enough. They're not out for the patient. The only people that can make a difference are the patients, and they're the ones that are at risk, and they're the ones that are suffering. So, and again, I find with my patients, and I know I've had them, or my dad had them, for multiple decades, they're very bright and they're savvy consumers. And if we give them the information, they know how to ask questions, they know how to find stuff. And many more of them, once they're learning the training differences, will say, I wasn't sure about this, so I asked if you're a physician, and that's how I figured it out. And so again, I think empowering patients is, we can try and pass laws till we're blue in the face. I don't think they make a difference. People find workarounds through laws, they find workarounds through money, they find workarounds in so many ways. But patients demanding whatever they want. And again, if they want a nurse practitioner, great. If they want a PA, great. If they want a physician, wonderful. I want it in patients' hands. I want them to be empowered to learn, understand, and to make a difference.
I think that's a wonderful part of the book, which is I don't think there's nearly enough transparency about what it means to be a nurse practitioner, what it means to be a physician. And I'm shocked by some of our leading figures, in quotes leading, that draw these equivalences and just cite studies and say, oh, it's definitely the same, and they rest so heavily on this idea that someone gave them a stamp of certification that they can practice. I mean, it's patients should fine. You want to do it this way, then patients should really know what it is they're signing up for. And I think your book is an important piece of that, in terms of being transparent about what it means to be a nurse practitioner. If you want to get nurse practitioner only care, then please read the book, and if you want that, go ahead.
Rebekah, where can they find the book? Where can the audience find the book?
So the book is called Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, and you can find it on Amazon. You can also find it at barnesandnoble.com. Terrific. And you can also visit our website, patientsatrisk.com.
That's great. And where can they follow you, starting with you, Rebekah?
My website is RebekahBernard.com.
Great. Niran?
And mine's NiranAlAgba.com.
Okay, great. It was great having you both, and it's a very important topic. It really is. I think it highlights a glaring crisis in another facet of a glaring crisis in healthcare. Thank you for writing it.
Thank you so much for having us.